Today I'm going to present a small but I think interesting and very promising study regarding the effect of low-level laser therapy for treatment of diabetic foot ulcers. We use the BQ Laser Pro, and I think it's important to say that it's an expensive research, so it was sponsored by BQ Laser, but no one between the researchers received any financial benefits from it. So low-level laser therapy is used for mainly pain relief, different medical musculoskeletal conditions, a bit of wound healing, and in anti-inflammatory conditions. It was first described by Andrew Mester in 1967. He showed accelerated healing of burn wounds in mice using the low-level laser therapy. But since then, many basic research studies were published, and many groups tried to figure out what are the pathways by which low-level laser therapy assists in wound healing. So you can see that it's increased ATP levels. It's important because it promotes proliferation and migration of keratinocyte endothelial cells, meaning blood vessels and fibroblasts. And you can see other mechanisms, collagen synthesis, and so on. But although the basic science evidence seems to be sound and serious, when you're going to clinical trials, the results are confusing and mixed. And I think that the main reason, like in other clinical trials, is the methodology of the studies. So let's talk about our study. Our study was double-blind clinical trial, meaning the patient didn't know what treatment they received, and neither us, the surgeon that followed the patients, didn't know which treatment they received. There were two groups, experimental and control. Both groups had standard of care. The experimental group had the active BQ Laser Pro, and the control group had a placebo BQ Laser Pro, and they couldn't differentiate between the two treatments. The treatment regimen was treated every day, 6 times a week, not on Saturdays, for 12 weeks. 8 minutes for every 4.5 centimeter square wound area. These are the technical details of the machine. I won't go over it. It's beyond the scope of this talk. But when you are looking about on the inclusion and the exclusion criteria, you can see that we almost did not exclude anyone. Besides ischemia, that we excluded patients with ABI level below 0.6, all patients got in, no matter the size of the wound, the depth of the wound, if it was infected, if they have chronic renal failure on hemodialysis, everybody got in. So it's rather small study. You see that we had 10 experimental and 10 control. Unfortunately, one died because of dialysis complication. The male to female ratio was similar. The patients, the experimental patient was a bit older, and you can see that we had 3 and 3 hemodialysis patients. This are already the result. And when we are looking on the closure of the wounds, the percent of closure of the wounds, you can see that in the low-level laser therapy, we have around 80 to 85% wound closure at the end point. And as you can see, and all of you can know that these are the numbers of around 15 to 20% of wound closure in our normal patients. When you look at the starting point and the end point using the low-level laser therapy, this is the average wound size, and you can see the big difference between the starting point and the end point in the experimental group compared to the control. And it was very significant statistically. And these are the details of the patient, but I won't go over it now. If you want, I can go back to it later. Here are some, the barcode here is not very good, but you can see that the wounds are closed with the treatment. Another endpoint that we looked at was 90% wound closure, who had more than 90% wound closure at the end point, and you can see that in the experimental group, 7 patients reached the end point, and on the control only 1, meaning that in 7 patients we had more than 90% wound closure. What are the limitations of this study? First of all, it's a small study and we need further studies. And it ended before we planned to finish it, mainly because of cost. It's a very, very expensive study to do double-blinded randomized control study. So in summary, when we look at the baseline, there was almost no difference between the experimental and control group characteristics, the patient's characteristics and the wound characteristics. But when we look at the end point, the low-level laser therapy seems to close the wound much better, and we had something like 80 to 85% wound closure. So in conclusion, BQ Laser Pro, or the low-level laser therapy that we use, is safe, and it seems to improve and facilitate diabetic wound healing. Of course, as I said, we need further studies, but I think it could be a very good adjuvant for a major unclinical need that we all treat. That's why we are going to study it more, and maybe to start treating our patient in the world with the BQ laser. Thank you.
Can you tell us what's the power of the study, since the results are very impressive and the cohort is very small?
The power is quite strong because, as you can see here, you can see the significant, the p-value. The p-value is very, very good. We were very surprised. I can tell you that in the beginning, I didn't believe that we can show anything to light a wound. It seemed to me very strange, but when you go over the literature and see the basic evidence behind it, and you see the result that we didn't know about the result until we opened the code. We were very surprised.
But power analysis, formal power analysis? Do you
what?
Have formal power analysis of the study?
Is high.
You show the significant impact of the placebo also?
Yeah, that's the standard of care. That's what we do in the clinic, you know.
No, they had the BQ, it's not...
yes. No, they had a placebo, the control.
They also improved significantly.
No, not like every patient in the control that we treat every day.
Please.
Yes, I'd like to make a comment on both of these studies, which are both very interesting. Both studies are incredibly underpowered. When you look at, my guess off the top of my head is you probably need to do about 400 or 500 patients with a diabetic foot ulcer to be adequately powered. Both of these studies should be titled Preliminary Experience with. And I think you made a very good comment before. We don't know why the answer, we don't know anything why yet. This is very good data to use as a benchmark. It says that both of these studies appear to be safe and have the merit to do further studies. We need bigger numbers and longer-term follow-up on both.
I completely agree. I completely agree. These are preliminary results. We need further studies, but it seems very promising, and that's why we're going to go on with the studies.
Dr. Melamed.
Okay, yes, so in continuation to what Mike have said, I want to say something about the study and the BQ laser. because BQ laser is very interesting invention, and I had a few years ago a sort of discussion with Mickey, the invention of the BQ laser, and he wanted us to do studies for him, but they never find it. So as you said, financially is a problem, but there hasn't been, I recommend you for the initial study, but as Mike Pinto said, this is only a preliminary one.
Agree.
But there hasn't been, I don't remember, a medical device that has been so much publication in the literature with so little data. Not in the medical literature, in the media, in newspapers, to promote it. For example, we got it in Rambam for example for use, maybe for 1 or 2 patients, and then it was said in the paper. It has been used in Rambam, it has been used in Ichilov and in other hospitals. And that's the problem, because I believe now, right now it will become that you use it in Hadassah. No, maybe it's wonderful, but the company should recruit the money. If they don't have the money, they should recruit inventors and to do proper clinical trials to show the efficacy and efficiency of the product in all the indications that they say it is.
Eyal, I completely agree with you. I think it's a small study, and Mike Pencil said it's a small study, and it's only the beginning, and I agree that we shouldn't be, that we shouldn't publicize, not publicize, promote things that we are not sure, but
I'm sorry.
that's a randomized controlled trial that we did. It's a small trial, but with a significant result.
I'm sorry, but we have to stop it, otherwise there will be no time for the...
One.
Just a small remark, short remark, please.
A shorter one?
Yeah, short.
I understand it was randomized, isn't it? Or
Yes, it was randomized.
well selected. And how many patients were weight-bearing on both groups?
Both the same.
How many?
It was a clinical. It done in the clinic, at the clinic. So
No, I'm asking you. You showed us an X-ray, a picture of TMA, which is a non-weight-bearing wound. But how many had weight-bearing wounds, and how many from those weight-bearing healed without contact cast or non-weight-bearing or anything else?
No one.
You don't have an answer.
No, I have the patient. The standard of care did not include cast. Did not include weight-bearing cast or total contact cast. It included only washing and polymem silver. So they were weight-bearing, these patients. They were ambulatory at home.
I'm really sorry. We have to stop.